Okay, so we're going to talk about chapter 3. We'll start off with our discussion with chapter 3, and then we'll talk about chapter 4. So, chapter 3, we're going to talk about the immune system. When I think about the immune system, the one thing that the word that I can give to describe it will be innovative. It's very smart and it's very adaptive. And so, when you talk about defending what we have, the foreign predators, or if we go to war, your immune system is going to attack pretty much everything. So it is our major defense mechanism, and it has invasion to the body. It really attacks it. So the big thing that it involves is that we have the thymus, and then we have the bone marrow, then we have secondary tissues called the adenoids, tonsils, and the spleen. So when we have the thymus gland, the interesting thing about that is your thymus gland is pretty big when you are born. And so as we are sitting around right now, you're listening to this, that thymus gland has atrophied and is actually non-existent. And so as you grow, T cells are located right here in your thymus. And so T cells come from that. And they fight against viruses, and that's really important when we move on and we talk about some other things. So you have your thymus gland, which is your main support system for your immunity. And then after that, we have our adenoids and tonsils. And so collecting at the back of the throat, anything that is foreign or is in there, you have your adenoids and tonsils. Unfortunately, in my case, my mom decided to get these removed. And so that makes us, my brother and I, more susceptible to have infections because we don't have that barrier when something comes in our mouth. So we'll talk about some key problems with the immune system. It usually results in one of three things: either a excessive or hyperactive response. This is typically an allergy. Then we have immunodeficiency, which is something called AIDS or HIV. And then we have autoimmune disease, which we're going to talk about, which would be lupus. And then you can also have attacks on foreign tissue from like a blood transfusion or transplant. And something really cool to know, someone can have an allergic reaction to a transplant, transfusion up to 14 days after administration of it. Isn't that pretty cool? So the immune response, the best way to basically talk about this is that you have um, your skin that tries to protect it, but then as it comes in, you have these different immune responses that come in. And so everything tries to lay dormant, and then when it notices that there's a break into the house, it's like your Brink's alarm system or ADT, it will go off and stimulate all these different attacks on these foreign organisms. And so we can have NK cells, we can have macrophages where it basically engulfs it and eats it. It's pretty cool. But the first thing is we have something called an antigen, and that is that foreign substance. And then from that antigen, antibodies are formed, and then the body uses those antibodies to attack those antigens. So acquired immune is what we have from T cells. So this is mainly from your thymus. We have different types of T cells that we have. We have cytotoxic T cells, we have helper T cells, and then suppressor T cells. The big thing with T cells is they are important in fighting off viruses. And so we're talking about HIV and why T cells are really important for that. With B cells are your antibodies, and what this does is it attacks against bacterial infections. So antigen and antibody reactions are stimulated the B cells. So antigen, antibody with the B here is responsible for the stimulation of the B cells, not the T cells, the B cells. So as far as we talk about immunity, you have the stem cell. which goes to the lymphatic system, and then from there it basically can go one of two ways. It can go to the bone marrow. If it goes to the bone marrow with B in front of it, it will turn into a B cell. If it goes to the thymus, it turns into a T cell. And then from the T cells, it gets split up into the different types of T cells that it has. So I'm going to talk about active versus passive immunity, and then we have natural and artificial. So the best way that I can describe this is, so let's see this pen. So your active natural, this is usually through when you contract the disease and you produce memory cells. So the best thing that I can think of is chickenpox. So chickenpox right there. So active natural, your body does this. Now passive is through usually breast milk. And when I say breast milk, it's really important. So we encourage mothers to actually breastfeed after they give birth. This is mainly because of the immune responses that they get and how beneficial it is to the baby's health. On the other side, active artificial is usually when you receive vaccinations. And so receiving a vaccination such as a varicella vaccination, which prevent you from getting an active natural immunity response because you've already have it. So these are usually dead antigens that gets injected into you, and we use these for pneumonia. These are actually really good. On the other side, we have passive artificial, and so this is where we have antibodies that get transfused through an IV, and these are IgG, IgM, whole multitude of things. But if someone has a weakness in their immune response, we'll use these antibodies to give them to them. So some people usually will have this. If you have lupus, I've seen people that have had, MS, that they're receiving immunoglobulins, and then lupus too, they have that. So immunodeficiency diseases, these usually can occur when there's inadequate or absent response of the immune system. This increases susceptibility to other diseases, and it can occur when we have problems with our B cells, T cells, the complement system, or the ability of the body to fight away the diseases and the antigens that come in. So this is really important to remember. You probably will see a test on this. So with B cells, you will have a deficiency and it will have bacterial infections. With T cells, this is mainly viruses. So what's more susceptible? If you have lack of B cells, then you're more susceptible to bacterial infections. If you have lack of T cells, you have more susceptibility to viral infections. These can be acquired or genetic. So you can be born with this deficiency, or you can get it acquired, which is something such as HIV and AIDS. So on that note, we'll talk about AIDS, but before we talk about AIDS, have to discuss that there actually, before you get to the AIDS part, you actually have HIV. HIV and AIDS are two completely different things. My biggest pet peeve is that people like to associate them as the same thing, but in reality, they're actually not. Two different things. So what happens with AIDS is a late stage of HIV, but before that, you have HIV. So with HIV, what it is it's an RNA replication virus where it takes over the body's immune system, replicates it with this HIV virus, saying that it's actually doing really good when in fact it's not. It's kind of like a imposter. So with people that are exposed to HIV, you can get exposed different ways. But usually, typically, we will have 1 to 2 weeks after exposure, we'll have these sore throat, fever, body aches. They really have flu-like symptoms. And the biggest thing that tips us off that it may be something would be lymphedema. If the lymph nodes are really enlarged, we have that. Diarrhea is very, very, very common. Um, Secondary to that, we have weight loss. And then we also have the fatigue because, long story short, you're losing your electrolytes that way. One other thing too is when it comes to the AIDS part, when the late stage, you have opportunistic infections. So we have pneumonia, and a pneumonia that we have is called PCP pneumonia. And so we have PCP pneumonia, which is a common cause. We have a fever, and then we have a skin cancer that is developed. And the skin cancer is called Kaposi's sarcoma. So we have some interesting things that can tell us if they have AIDS. Something about this is that there's actually 2 types of HIV. A lot of people do not realize that there's actually 2 types. So there's type 1 and type 2. The most common one in the United States in the Western civilization is actually type 1. Type 2 only exists in Africa. Isn't that interesting? So type 2 is through Africa. The one thing that HIV does is it attacks the helper T cells, which are called the CD4 cells. So we see the progression of HIV by monitoring someone's T cell count, or actually helper T cell count. When the T cell count becomes low, that is usually a definition of when we move from HIV to AIDS. Someone can have HIV for 25, 30 years plus, or they can have it for 10 years and then progress. It's all dependent on the person. So typically they say with AIDS, the time from infection and death is approximately 10 years. That's actually not so much the case. I've seen people, once it goes into the AIDS portion, they usually do not do very well. When their immune system is very low, they have the opportunistic infections, they develop the PCP pneumonia or the Kaposi sarcoma, and then succumb to that pretty quickly, usually within a matter of months. This is spread by direct sexual contact, also through blood products, sharing needles, and everything like that. What we do to confirm this, the technology is pretty interesting. We do a enzyme-linked immunosorbent assay, which is ELSA test, and typically that can be negative for the first couple of months. If it is positive, what we do, we confirm it with a Western blot test, and then we look at the T cell count to see where they are at within the progression, whether it's HIV or whether it's, say, AIDS. Now, there are different tests too that we can have. This ELSA test, which is the most common that we do. However, you can do a quicker one that is an HIV RNA test to see if there's RNA replication already. It's sooner, usually within the first less than 6 months, and that's more accurate. So, case in point, what they do with porn stars is they have to have frequent HIV testing. And so the ELSA test is not really that effective because less than 6 months, you can actually test negative when you're actually positive. So they do now, which is a RNA HIV test, which is within 10 days of exposure, it will show positive and it's more accurate. So a lot of porn industry is going to that test. There's no treatment for AIDS, but there is treatment for HIV. The goal is to have antiviral therapy, and so it's called HAART therapy, so highly active antiretroviral therapy or treatment is what it's also referred as. So you have nucleoside inhibitors, and then you have protease inhibitors. And so these are usually typically 4 medications that are in one pill that has been prescribed and is pretty effective. It's just a pill a day. When this was new, you would actually have to take 4 different pills and it was actually not the best thing to have for someone that had HIV. So, with that being said, I want to show something to you guys.
I was trying to figure out what's right and what's wrong. A law, something is against the law, then it's telling society that that is unacceptable, that's bad behavior. And I think the severity of that punishment tells you how bad you are as a person. You're a Class B felon, lifetime sex offender. You are a very, very, very bad person. You did a very, very, very bad thing. And so that's just, programmed into you, and, you go through the correctional system and everyone's telling you the same thing, and you're just like, I'm a very bad person, very bad person.
Today in court, Rouse was charged with another count of first-degree assault. The special statute covers passing on AIDS or poisoning someone with a destructive substance.
The prosecutor asked that another charge, unlawful use of a harmful device, in this case Alan's HIV status, be added. That's a 15-year felony. The judge agreed.
They learned that Chambers is HIV positive. Fort Mill police upped the charge from simple assault to assault and battery with intent to kill.
More serious charges were added because the defendant is HIV positive.
Because the suspect has HIV, he's facing some unusually serious charges.
Authorities, though, still consider him a danger as long as he can infect others.
HIV, gay, sex, all wrapped into one. It's just like it's a gift on a platter. Whatever the facts are, whatever the science is, it does not matter.
Come home one day and you just kind of get a feel, someone's been in your apartment or your home. And I looked on the counter and I saw a document, which was a search warrant, left by the sex crime detective. They showed up to arrest me, and they arrested me at work.
So me getting HIV, it was like a shock. It was just like, how did I get this? How did it hit the Howells house? How did it hit here? I'm a church girl. My dad's a pastor. He's still a pastor. So we grew up in church. Hallelujah, thank you, Jesus, all day long. Being a good wife, and I did the right thing, and because of an affair that happened in my marriage by my spouse at the time, that's how I got it. He looked at me just like a man he looked at me just as if I was negative, just like I'm normal. How do I even disclose my status? How do I do this? How do I get those words out my mouth? HIV. I was afraid of how he was going to look at me. I was afraid that how he would judge me. And the only thing I could say is, you need to get a condom. I had so many thoughts going on my head when I was sitting in court. Like, what if I walk out and so many people walking around calling me the monster? What if I get labeled a sex offender? What if they take my kids away from me? If convicted, I was looking at 8 to 12 years. And
if convicted, then the sentence would be anywhere from 0 to 10 years.
The full 25 years.
The Attorney General is arguing Williams should be held indefinitely under a newly enacted civil confinement law.
New York State wants to find another way to keep him behind bars permanently.
I felt like I went out and killed a whole bunch of people. They made me feel like that.
I mean, one thing I always told myself, and I've shared with others, that I would never end up at a police station. I would never go to jail because I felt like I was always a law-abiding citizen. My mother had me at a very young age. 12 when she conceived me and 13 when she had me. Yeah. So I always used to say that I'm before my time because she had me so young. So I was a straight A student growing up and just, very successful. The very good thing that I said would never happen to me or that I would find myself in is the very thing that was happening to me.
I had to register as a sex offender every 3 months. versus certain pedophiles and other, sexual crimes, it's like 6 months. I mean, I was like very dangerous in their eyes. Couldn't be around minors without being supervised by their parents. To wear a GPS ankle bracelet and be monitored 24 hours a day. No alcohol in the house. I could not drink. I had to be home by midnight. I couldn't watch pornography at all. They could ask me to bring my computer in at any time to interrogate it. I couldn't be on any social networking, not even Facebook. That's where pictures of my nieces and nephews are. I had to go through all these psychological tests to take some allometric assessment test to see what really stimulates me sexually, which I think has something to do with putting a device on my penis. Polygraph tests. Every 6 months for the rest of my life, you're going to hook me up to this machine. You're going to ask me these same inane questions. I can't live like that. And I can't live under that probation system that is so suffocating and, just cruel.
On Fox, a warning from a woman infected with
the arrest of an HIV-positive prostitute
warning the public tonight about
for
this
hiding
man.
his
He admitted he is
HIV-positive
HIV
status
positive
at swinger
and
parties. The man called the HIV predator will make
the
his
so-called
case.
HIV predator
I
for
think
someone
you should
with
get the
intent to
sentence.
kill.
They are
They don't have
reducing, calling him a threat to society.
The media, the military courts, whatever, they could call me whatever they wanted to call me, but I knew I wasn't those names that they were calling me. I just was a human being trying to, just wanted to fit in, just wanted to be loved, but it seemed like that three-letter word, HIV, just had me stuck. I didn't realize the stigma on HIV and AIDS until I was diagnosed. Many people not wanting to go get tested, because they're afraid that if tested positive, if they had unprotected sex with someone and someone tries to get them in trouble.
Him reacting, the way he reacted is the way that is the reason why most people are afraid to disclose, because of the fear and because of the stigma that comes from it.
The HIV criminalization needs to be changed.
My stepfather is a promise-keeping Baptist. He is salt of the earth, veterinarian, small town. And I told him this stuff, and he's just like, that is horse shit.
But what I've done since then is just devoted myself to advocacy, to volunteering, to getting involved and learning more about HIV and AIDS, and with hopes that could open the door for me, because obviously this is my life now.
It's actually a pretty good documentary about the stigma that HIV causes. There's a lot. It's really much of an understatement. So moving on, we'll talk about SLE, which is systemic lupus erythematosus. And so what this is SLE is a name for lupus. It's a type of lupus. There are different types, but this is the most well-known one. And so what lupus is an autoimmune disease, basically where the body attacks itself. And so this produces inflammation of the skin, joints, the nervous system, kidneys, and lungs. And so most people with this will actually die of kidneys or lung problems because of this inflammation. So if anyone's going to nursing or even MA, this is a big part to know that with the kidneys and lungs are affected by SLE. The characteristic of SLE is a butterfly rash on the face and neck. So if I ask you what is a characteristic butterfly rash on the face and neck, that will actually be lupus. And so you see here, butterfly rash along the face, and then this is some discoid lesions on the hand that is produced by this. So the signs and symptoms that we have, we really do not know what causes it. We know it occurs most often in young women, 30s to 40s typically. It can happen sooner though. It does occur in guys, but not too often. So exposure to sun may aggravate rashes. People may begin with a fever, fatigue, joint pain. Raynaud's phenomenon is something where there's a hand condition. So it kind of looks like this, with there's discoloration and sensitivity of the hands. That's Raynaud's disease. But this does affect a lot of people. My aunt has SLE lupus, and it's been very unfortunate. Like I said, this is autoimmune disorder. Um, Events that precipitate these exacerbations are a lot with stress, pregnancy, or overexposure to ultraviolet light, especially in the summertime. What we do is it's very difficult for us to diagnose lupus. What we have to have is 4 or more symptoms, and then we do a blood test to look for elevated antibodies and rheumatoid factors. So we look for rheumatoid diseases, we look for autoimmune diseases, but one thing that they have to have 4 of these. So they have to have a butterfly rash, they have to have the discoid skin lesions, photosensitivity, polyarthritis, so arthritis in many joints, and then they have to have the antibodies within the blood. So 4 out of those 5, then we can diagnose them with SLE. We use the anti-DNA test, which is most specific, but only when lupus is active. But in most cases, they usually will have anti-inflammatory drugs, but severe cases, they will usually need steroids to suppress their immune system. Prognosis, it depends on organ involvement. Outlook does get better with improved technology. However, these patients are more prone to cancers such as leukemia and lymphoma, and then breast cancers that we see with females. So moving on to that, we have rheumatoid arthritis, and what rheumatoid arthritis is a inflammatory disease of the joints. And so when you have these nodules, and a lot of people think that it is, oh, it's just arthritis, but there's different forms of arthritis. So rheumatoid arthritis is the most severe, and it actually is not a bone disorder per se, is actually an autoimmune disorder. And so basically you have the joints, the synovial joints with the knees and the hands, and those are affected where inside the joints the body is attacking that joint itself. This does occur in more women and can start in the 40s, 50s, and so on. So if left untreated, it can destroy cartilage. These hands are actually deformed and good. It's actually really bad to see. So I got a picture right here. So you see the elderly people, they have these nodules on their joints. So what this is the joint is so inflamed because the body is attacking itself on these joints. So you have a regular bone synovial membrane right here. You have different forms where the body basically is attacking itself within here, and then it causes some erosion. This would be from osteoporosis, where the bone is weak. So this is going to be your rheumatoid arthritis right here. The joint is pretty much intact, as you can see, compared to this, where this is from a rubbing friction. This is an autoimmune, the body attacking itself. So what happens with these people? We have the weight loss, we have persistent low-grade fever, general weakness, joint stiffness is a big thing. You have swelling of the area, pain, tenderness, and a lot of redness and warmth because the red blood cells are attacking those joints for these people. The joints that are generally affected is the fingers, the wrists, the knees, the ankles, and the toes. Most commonly, you will see this in the hands. It's where more noticeable. The reason why it occurs, we don't know. It may be hereditary or infections may trigger it. What we do is diagnosing these based on review of the symptoms, looking at the family history. We do a physical exam, and then we do a blood test to see rheumatoid factor is elevated in these people, which means the body is attacking itself. And with the elevated rheumatoid factor, that gives name to its characteristic of rheumatoid arthritis. So what we do for these people, we try to use the term rest ice, compressions, elevation. So we have them rest. We do special exercises. We do pain medication as needed. We do anti-inflammatory drugs such as Motrin that they take. And then they actually have splints for activities of daily living to kind of help them out. The prognosis that they have depends on how bad and compliant they are with treatment and trying to reverse the progression of this disease. The next disorder that we're going to talk about is called multiple sclerosis. So when I say multiple sclerosis, it also stands for MS. So multiple sclerosis is a disease that attacks the central nervous system, and most importantly, it attacks the myelin sheath. So MS, myelin sheath. So a disease, when I say MS, what you should say is myelin sheath, or think about myelin sheath. In return, we're thinking about multiple sclerosis. So multiple sclerosis attacks the myelin sheath. The best way to describe this is, when I describe it, is this is like an electrical impulse right here. So you have an electrical impulse that goes from the brain to the spinal cord to the rest of the body. What happens with MS is you have typically insulation, just like within your own house. Every electrical wire has insulation, or well, it should have insulation. What that insulation is it shields and allows this to conduct the electricity the way it should. What happens when you come in contact with, say for example, myelin sheath, what happens is the myelin gets attacked by the body. So now you have signals that are free to bounce off into places that it shouldn't. So this is a well-traveled conduction right here. But here with the myelin sheath or multiple sclerosis, it doesn't know, it's not insulated, so the signal goes all over the place. So you have a lot of disconnection between it. So they have a lot of muscle or neurological symptoms, including weakness or numbness in the limbs. They have loss of vision. They could have double vision, unsteady balance, trouble speaking, hearing, so forth. It causes a lot of problems. We don't know what really causes it. It just is an autoimmune disorder that attacks the myelin sheath. So like I said, MS, myelin sheath. So it does happen more in women. 20 to 40 years of age is where we see this most commonly. I have a friend, he's 34 years old and just got diagnosed with MS. There is different episodes that they have with MS. So the types that we have is relapsing, remitting. So what happens is the body attacks the myelin sheath. Then it kind of relapses. They have some recovery. Then it attacks again. And then it keeps getting better, it attacks again. Primary progressive is where the disease progresses and it doesn't relapse. It doesn't have any break. And so it doesn't have any remissions. Now, progressive relapsing is when it still keeps getting worse, and then each time it gets bad or they have problems, it gets worse and worse each time. And they have some periods of relapse, but it really depends on the person. Usually what happens, the acute attacks are treated with steroids. How we also treat this is we give immunoglobulins. There's also injections that you can give. My friend is on multiple pills right now a day. I think he's up to 8 pills that he takes every day, and injections every other day. It is a more favorable prognosis if you catch it while you're young, but it's really hard. So moving on, we have myasthenia gravis. What myasthenia gravis is a neuromuscular disorder. So this is really important. When someone has any neuromuscular disorder, that attacks the body's ability. So when a signal is onto a neuron, for it to inhibit that and then do its function. When you have a neuromuscular disease, the body is attacking those receptors and so you can't have any binding on it. So you have extreme muscle weakness, and this is not good. Typically with myasthenia gravis, it's really gradual, and it can really be lethal. So what happens with this, we have drooping in the face. Kind of looks like a stroke, doesn't look like a stroke because you have both bilateral drooping. With a stroke, you only have one side of your body drooping, so that's a way that we can diagnose it pretty quickly. The eyes are pretty droopy, and then the weakness of the face. As it goes on, each hour it gets worse and worse and worse. And so people that have this, usually if they're under a lot of stress, usually this makes it a lot worse. They can have paralysis that occurs where they stop breathing, and then they're required to have intubation. Usually, unfortunately, I hate to say this, affects women 20 to 40 years. I've had patients that have had myasthenia gravis, and it has been within this age. Men is infrequent and occurs later in life. This is an autoimmune mechanism, so the body's neuromuscular junction receptors that they have there is not allowing the key to basically go in and unlock. The key fits, but it's not doing the function of actually unlocking the door. So in this, with myasthenia gravis, they have antibodies towards acetylcholine. And acetylcholine, this is really important because that's your muscle contractions right there. That is responsible for muscle contractions. So if it blocks acetylcholine, then you have paralysis. Never a good thing. So like I said, we diagnose, we look at their eyes to see drooping eyes, we do an antibody test, we look for their thymus, and we do a tensilon test, which is pretty interesting to do. The treatments that we do for it based on age, what we do is anticholinesterase drugs. We do get rid of the thymus. We also do steroids and immunosuppression. If they're having a crisis, we will have to intubate them. Another thing too for the pharmacy people, one drug that is not good for any of these patients that have myasthenia gravis is any pain medication. Most importantly, there's a drug called fentanyl or Duragesic, which is really bad for these patients to have. You can cause really bad paralysis, and you can pretty much kill them. Also, a drug that we have to induce intubation called succinylcholine that inhibits the acetylcholine receptors. It will make paralysis profound, where you sedate someone. Usually, that drug wears off within 3 to 5 minutes. After 3 to 5 minutes, they still have the paralysis, and we're like, oh crap, what's wrong? And that's when we know we shouldn't have given that. So that right there is chapter 3. So the next thing I'm going to pull up that we have is chapter 4. And this is going to be the endocrine system. So moving on to the autoimmune disorders, where the body kind of attacks itself, or it's dormant, or lack of any T cells or B cells, we're going to talk about the endocrine system. So endocrine system really, this is interesting too. Endocrine system is how everything drives it. It takes a hormone, which is produced by a couple different things that we're going to talk about, to produce a response. And so the body triggers a hormone release, and then it sends the chemical messengers that act as, that are either proteins or steroids that act on that specific response that it's trying to get, or target organ, and then it happens. So the endocrine system has a lot of hormones. The most common hormones that we have are tropic hormones. So they stimulate secretion of other hormones, and so we usually have gonadotropins, which are sexual hormones. Typically, this is really easy when it comes to endocrine disorders. Endocrine disorders result of either having too much of their hormone or not enough. It's either one or the other. Too much or not enough. So we're going to talk about some conditions that are because of that. So we have the pituitary gland. So the pituitary gland, and this thing you really want to know. because the next quiz I'm going to ask you some questions about some of these hormones, and I want you to remember kind of what they do. So, for starters, the growth hormone, then you have your pituitary gland, you have your frontal portion right here, and then you have your back portion. The frontal portion is called the adrenophysis, and then the back portion is called the hypophysis. So anterior pituitary, posterior pituitary, or hypophysis. So the growth hormone, what that does, it stimulates tissue growth. So our growing. Our thyroid stimulating hormone, what that does is that produces the thyroid to release TSH. And then we have T3 and then T4. ACTH is adrenal corticotropin hormone. It's released by the adrenal glands. Usually, this is cortical hormones. This is usually stress. That's what this is. Then moving on, some other important ones is your prolactin. Prolactin stimulates breast glandular tissue. So this is for the mother. You have a lot of prolactin levels to stimulate production of milk. And then oxytocin, this is really important too, because that does lactation, but mainly we use it for uterine contraction. And so oxytocin, I should just say pitocin, because we give this to stimulate actually contractions on a pregnant woman. And then lastly, we have the adrenal antidiuretic hormone, which is also called vasopressin, which has kidney water reabsorption. So we're going to talk about disorders like growth hormone, thyroid hormone, oxytocin, and ADH is what we're going to talk about in the next couple slides. So usually when we diagnose people, we have to take all the symptoms into play. It can be really hard to diagnose someone with an endocrine disorder. I'm going to be honest with you, it's not really easy to do right away. We do one of two things. Like I said, if there's too much, then we usually do radiation and surgery. If it's too little, then we replace it. Pretty simple. So talk about hyperpituitarism. This is with that pituitary gland where there's that front and back. So with this, it has a lot of growth hormone secretion, and it leads to two different things. So the first one is gigantism. This is a big thing that occurs before puberty. So make sure you remember this one right here. It occurs before puberty. So this is before the epiphyseal plates close. So with that being said, usually they have pretty long bones, and they're like really tall. So they have long bones, and their femurs are really big, and the one thing, they have sexual development that's kind of impaired. So what this is, it's usually caused by a tumor on the anterior pituitary, the front part of it. What we do, we see high levels of human growth hormone on a radio immunosorbent assay, and then we do our CT or MRI and show the lesion, and then we look at a CAT scan, and we also see long bones, especially in the legs and arms. So what we do with this, since it's too much, we do one of two things. We take the tumor away, or we basically will do radiation, shrink it. What we do, we got to prevent this early enough before it causes a lot of harm. So gigantism, that occurs with children. Now on the flip side, you have acromegaly, and when I think of acromegaly, I think of the A right here. And then what helps me is that it occurs with adults. So this is where you have that same thing, hypersecretion of the growth hormone, but occurs after puberty, that A there again. and the closure of the epiphyseal plate. So with that being said, they have thickening of the bones of their jaw, which is really big, and their hands. So they have really big hands, really big feet, really big jaw. We look at them, we do two things. We try to do radiation or we do surgery. Same thing of diagnosing it. This is a timeline of someone that has acromegaly. This is, look at the face here. It gets bigger, more pronounced, and then really big. So from start to finish, you have twice the amount and thickening of the bone within a matter of 11 years. Kind of crazy. So moving on, we have diabetes insipidus. A lot of people, when they hear the word diabetes, they're very quick to think of a sugar problem, but it's actually not. We refer to in the medical field DI, diabetes insipidus. This is not good. Anytime you hear diabetes insipidus, it's nothing to do with a sugar problem. I wish they would change the name to it, to something else, because it confuses a lot of people when they hear the word diabetes. What this is usually you have antidiuretic hormone, which tries to keep your body from losing all the fluids. Usually as a result of trauma to the posterior pituitary gland, so head injuries is what we see, which will cause diabetes insipidus. So when these people have diabetes insipidus, they will urinate large amounts, and it's very dilute. It doesn't have any gravity to it. There's nothing in it. It's just all fluid. So basically the person can die because of having diabetes insipidus. They will basically urinate every single fluid that they have and have huge amounts of problem. It's never a good thing when they have this. So it occurs more in men. Go figure. Men are risk takers, and so they like to do a lot of silly things. So we will see, because of trauma, you know how I said the trauma? Head trauma, which will cause this through an intracranial lesion. Someone can have nephrogenic diabetes, insipidus. This is mainly because of damage of like a kidney stone and so forth. But usually early adults, so forth. We see, like I said, the urine is low gravity. We do a test with this. And so the interesting thing that we do to treat this is that we will treat it with vasopressin, and it's a nasal spray. We give this spray, which is a nasal spray, or it's another thing called DDAVP. So all the hospitals actually have this for trauma patients. And we will, this is most commonly with head injuries. When we give this, this is really good. Usually a pretty good prognosis. Something interesting for the pharmacy people, these drugs with the nasal spray is actually given to kids for bedwetting. So we actually give that same spray for kids right before they go to bed at night if they wet the bed, to actually prevent them from wetting the bed. We give that same thing. So we're going to talk about thyroid disorders. The most common one that we have is a goiter, which is non-toxic. It's usually in women, and they have a huge amounts of, they have a lack of iodine, and so not having enough iodine. This isn't a problem in the United States because if you eat salt is ionized, so you have that, which is really good. But we see that there's low lack of iodine, which makes the body deficient in thyroid, and so hormones, and then it starts to enlarge. Another thing too is you can have ingestion of large amounts of goiterogenic foods such as turnips or cabbage, or even drugs such as lithium, which are really bad to someone that is more susceptible to this. The early stage, what we do is we just replace iodine in the diet. Good prognosis if we replace it. And if they have goiter that's unresponsive to any treatment, then what we do is we take the thyroid out. So moving on, we have Hashimoto's disease, which is a disease where the body attacks the thyroid. So this is pretty much a chapter 3 problem if you ask me, but we're talking about it in this chapter because it's an endocrine disorder. So this is not really a lack of hormone or anything like that. It's the body that actually attacks itself. And so you have an enlargement of the thyroid. And so this is your hypothyroidism. This is where you have the weight gain, mental apathy, and you have sensitivity to cold. It's not fun at all. This is autoimmune, where the body attacks itself. The gland enlarges, produces inflammatory processes and scars towards the end. What we have to do is we look at a thyroid test by radioactive iodine uptake test. And so we have the person drink some iodine. We see how the thyroid takes it, if it takes it normally or it is actually pretty slow. We see that the thyroid stimulating hormone is there, but the body's there's antibodies present that are attacking it. So we do treatment by just replacing the hormone because there's not that much there. So it's not too bad. With Graves' disease is hyperthyroidism, where you have too much of the thyroid problem. When I think of hyperthyroidism or Graves' disease, this is not always a bad thing. It's like having a constant Red Bull. So having that constant Red Bull, it's where you have an increased amount of thyroid hormone, where your body is very hyperactive. You can eat a lot of food, not gain a lot of weight. You or stay up for a long period of time. That's all good in the short term, but afterwards, it will definitely wear and tear on you. So one thing that's interesting that we see that have someone that has hyperthyroidism is they will have these pronounced eyes that are bulging. Actually, I had a coworker, she looked just like this person, kind of weird, and her eyes are protruded. And I've seen other friends and colleagues of my brother that I've kind of asked them, saw that their eyes were protruding, and said, by any chance, do you have hyperthyroidism? And yeah, they do. Most of the time, what we do for this is we will take the thyroid out. We have thyroidectomy and remove it. We do give in the short term drugs called beta blockers. These are drugs, if you're in the pharmacology program, these are drugs that end with an LOL at the end of them, which is a beta blocker. So it's a metoprolol, Topra, Lopressor, atenolol. It's another drug, and what that is, that will slow down the heart because the body's acting so much. So prognosis, usually they do really well. If we take the thyroid out, they do pretty darn good with this. So moving on, we talked about hyperthyroidism. Now we're going to talk about hypothyroidism. So hypothyroidism is where you have a lack of that thyroid hormone. So it's decreased. And with cretism, look at this C. It's congenital. And it usually affects children. So childhood congenital C cretism. Usually the thyroid is usually absent, or they don't even have any thyroid hormones. This is never a good thing. These child that have this are developmentally challenged. They usually do not survive much afterwards. And so what we try to do is do supportive care to them and try to do that. If we reverse it ahead of time, it's usually good, but if not, they have the mental retardation that's for the rest of their life. In the adult phase, we have maxedema, which is also termed as a maxedema coma, which is where someone has severe hypothyroidism, where their body is not having much of that thyroid hormone. Their face becomes bloated, thick tongues, puffy eyelid. In severe crisis, maxedema coma, they will have to be intubated, given steroids, so forth like that. With maxedema coma, it's usually impairment of the ability to process T4. So it can be from radiation, usually medical imaging or non-medical imaging. When you go to the dentist's office, they usually put something around your chest and neck to protect your thyroid. It's for that radiation, so that you're not shrinking the thyroid. So how we diagnose this, we do a TSH test, we do a T3, T4 samples, see that those are low, and then we treat them with T4. And once we replace the hormones, it's usually pretty good. So the next common things that we talk about is we talk about diabetes, mellitus, and so the best way I can tell you there's two types of diabetes. So there's type 1 and then there's type 2 diabetes. There's actually three types of diabetes now that I think about it. Type 1, type 2, type 3. So with diabetes mellitus, there is three types. Type 1 is usually called juvenile diabetes. This is often termed as insulin-dependent diabetes mellitus. And so this is where you get the IDDM. Usually these occur before age 30. This is where the person has little or no insulin secreted by the pancreas of the patient. Type 2 diabetes is more common. One of the common leading causes of death and disability that we have is type 2 diabetes because it's related strictly to one thing and one thing only, which is obesity. And so I'll talk about those in a minute with that. And then the third type is type 3, which is pregnancy related. So it's something called gestational diabetes, which is during pregnancy. So unfortunately, a guy cannot have type 3 diabetes. So let me break this down for you. I go to our blackboard, see if I can draw something. Okay, so what happens on normal response, so you have, let's do a bar graph right here. So I'm going to have this pencil. Let's do this. So I'm going to draw a bar graph right now. Okay, so you have a bar graph right here. And what happens is our normal blood sugar typically is between 80, take that back, usually between, normal blood sugar usually is between 60, usually 100, or like 110. So we like it to be above 60. So let's say you are a normal person, non-diabetic. So this is going to show what happens. So as your body eats something, and you have a bolus of food, as you eat something, your blood sugars rise. So that's good for a normal person. What happens is then you have insulin, which will bring that person slowly back to a baseline between that 60 and 100 mark. So this is a normal body's reaction. Another way that your body gets rid of the excess sugar is a good thing. So say, for example, you drink a nice Mountain Dew. Well, Mountain Dew is probably the worst thing you can ever have, but it has a lot of sugar in it. So as you drink a lot of sugar, your body tries to compensate, and most likely about 20-25 minutes after you have that whole amount of that whole big thing of Mountain Dew, you're going to want to go to the bathroom. You're going to want to urinate. So your body tries to get rid of that through the insulin, secreting the insulin, and then getting rid of it that way. So that's a normal pathophysiology of the insulin and how the body works. And that's secreted by the pancreas. So now when someone has type 1 diabetes, so we'll do that same thing here. When they have type 1 diabetes, they start to eat. The blood sugar will start to go high. Normally, there's a spike, there's usually something that would stop it, which would be the insulin production to make it go down. Remember how I just showed you it went down like that? Well, unfortunately, they do not have that insulin reaction. So in return, their body starts to have all that extra sugar float around the system. So then what happens is they have the body will secrete insulin. They will have insulin, which will then slowly bring it down. The problem, though, is the blood sugars with a type 1 diabetic are not really fully controlled. They have these spikes that go up and then go down. They have some spikes that go up and then go down. Typically, these people result in high blood sugars, and then they don't have, they only have hypoglycemia usually when the person will give themselves too much insulin, and it will bring them below that baseline where their blood sugar is in the 20s and 30s, and they will act like they are drunk. And what happens when someone's sugar is that low, the best thing that you can do for them is to get something called glucagon. Try not to put anything in their mouth. You can do some orange juice, but you got to be very careful. A lot of people try to think, well, this person's a diabetic, and what I'm going to do is I'm going to give them a boatload of sugar. So their sugar is completely down here, below normal, and so I'm going to have them drink all this sugar. Well, what happens is when they drink all that sugar, it brings them past normal, and it brings them all the way up. Now they have too much sugar in their body. Then on top of that, they have to take insulin again to slowly bring their sugars down. When you have a spike just like this of blood sugar, it's never a good thing for the patient. It's really bad. This really affects them. They are sore for days. So that is something that's related to type 1 diabetes. Now let's talk about type 2. So type 2 diabetes. This is from when, do my little bar graph again. So with type 2 diabetes, what happens is there is a lot of, with type 2 diabetes, there is a lot of sugar. They consume a lot of sugar. So your body does this amount. So what happens over time, since your blood sugars are running at this level, you have your insulin that also goes up to try to match the demands. So as your body goes up and tries to match the demands, so it will bring these down to a normal level. Unfortunately, since there's a lot of insulin within the system, these people are subsequent to having periods, believe it or not, of low blood sugar. They have low blood sugar because they have so much insulin floating out there that their body is just so used to having so much sugar that now it has way too much insulin, and they have all these periods of these spikes that go up and down and up and down. So what they're prescribed is a pill called glucophage, and that is a sugar pill that they use to actually keep their levels consistent. The one thing that can only fix this is having losing weight, and as they lose weight, they become normal. They start to bring down the demand and eating a better diet. So this is completely 100% reversible, unfortunately, when someone has that. So that's diabetes, kind of in a nutshell. Hopefully you can understand my little drawings right here. It'd be easier if I had a touchscreen, but unfortunately I try to make what's best. So that is all that we have after this lecture. So make sure you watch that. What you're going to have is, for this week, you're going to have a quiz that's going to open up too. And then you will have an exit ticket, which is going to open up as well. So I'm not going to give that away, but you have the lecture here for you, and then you have the quiz that will be open. So make sure you guys get those done, and I really do appreciate your patience, and look forward to talking to you soon. Also, during class, I'm going to be available from home. I'm going to try to do my best and go on this discussion board, so if you have questions while you're taking your quiz and doing the exit ticket, that I can try to help you out. Okay, take care.